everyone. Welcome. I'm going to sit down now.
So we have in our country an opioid crisis, an opioid epidemic. And that's what our group is here to share with you about and to hear some things from you about how it's impacted your lives also. To give you an idea as to how serious it is, I have some numbers here. The first is the list of people in Wisconsin who died from traffic accidents, from gun-related deaths, and from opioid-related deaths. So the numbers are 594, 624, and 932. Come on in. Hi. So who would like to venture a guess as to which one of these is the opioid death? So it's guns, traffic, and opioids. Diane, you're going to guess? 932. Yep. So 932 opioid-related deaths in Wisconsin in 2017, 624 from gun deaths, and 594 from traffic accidents. Another way of measuring it is the degree in which, over the period of the last 20 years, how many deaths there have been in the United States related to opioid illnesses. And there's three numbers here. The first is 620,000, the next is 418,000, and the last one is 400,000. So one of them is the number of deaths in Civil War of Americans. The second is the number of deaths in World War II for Americans, and the third is number from opioids. Who would venture a guess as to which of these is the opioids?
418,000.
Dale. Any other guesses? Dale is close. It's actually, the 418 is the number of U.S. deaths in World War II. 620 is Civil War. And then 400,000. And that's kind of a general number, and it's increasing. So it's not an even. So how frequently are people being prescribed opioids for chronic pain, for surgery, whatever it might be? And here is another set of figures. 1 in 6, like 1 out of 6 of us during the past year would have been prescribed an opioid, or 1 in 16 of us, or 1 in 26. Who would venture a guess? This is very hard to figure out, because who would even have heard of this statistic? So what would be your guess as to, Dale, what would be your
1 in 26.
Dale is guessing 1 in 26. Any other brave souls? 1 in 16? It's actually 1 in 6.
Wow.
Every year, 1 out of 6 Wisconsin citizens is prescribed an opioid. So that tells you how common it is. There's another statistic that was in the paper just recently that between 2006 and 2012, 310 million opioids were sent to Milwaukee County. That's 47 per resident per year. What in the world? What happens to all those opioids during that time? So these are general statistics that I'm offering to you, but more specifically, I'd like to know from those people gathered here today, how many of you know someone whose family member or friend has been seriously impacted either by death or by chronic illness because of opioids? Just raise your hand. If you know someone, raise it high so we can actually look around and see how many people know someone who's, yeah, it's remarkable. Well over half of us know someone whose lives have been seriously impacted. So we're going to move from now these general ideas to more specific experiences with opioids, and we have 3 people who are going to talk to that. The first is Pastor Molly Teresa, and Molly's going to share some about the tragedy in her life because of opioids. Molly?
Good morning.
Good morning.
I'm thankful to be here. I wish I didn't have to be. 3 years ago, on August 18th, on a rainy summer morning when I had just returned from vacation, And you have mountains of laundry you have to do, and you're just thinking about getting back into the work, which for me was a Lutheran pastor. And the phone rang. And at the other end, my daughter was hysterical. "Sit down, Mom." I said, "What is it?" "Mom, are you sitting down? Sit down." And in those few short seconds, you're going to hear some awful news. You don't know what it is. I said, "I'm sitting down. What is it?" And she said the words, 2 words. "Justin's dead." Justin was my oldest son, who was vibrant in personality, intelligent. He was the kind of boy in high school that embraced the bully and then made everybody else do it too. He had musical talent. He had been through law school, using. He had 2 small children, and he had been sober for 6 years. What had happened is he had moved with his children to Colorado for a job. And that summer, while his kids were out visiting his mother in Wisconsin, he started using again. And he got himself some fentanyl. And one night he came home from work while his children were sleeping, opened a bottle of wine, and used. So the next morning at 6 o'clock, when my grandson, his son Elliot, who was 11 years old, came down, he heard the water running in the powder room, and he found his father dead. He called his sister, Chloe, who was 2 years younger, and these 2 frantic children called 911. Now, I don't know if you know what happens when 911 is called. The police came, they were just 2 blocks away, so they came immediately. And immediately they sat the kids down and started questioning them. Children didn't even have a chance. I mean, the EMTs worked on him, but they knew right away it was too late. So the children had to sit and be questioned, and then because no one was close, they had to be taken down to the police station to await their other grandparents to pick them up. The image or thought of that to me is unbearable. There's not a day that goes by that I don't think of that moment. But even worse, that I don't think of his 2 sweet children. Beautiful children whose lives have been permanently changed, not only by their father's addiction, but more importantly by the way he died. I went from being an observer of this crisis to at the epicenter. I went from being a pastor who referred people by way of, let's look up the closest AA meeting, or let's call somebody who's in addiction counseling, and handing that off, to being a pastor who is in the midst of things, and all of it started making sense. This is something we have to do at a congregational level. We can no longer stigmatize this disease as a disease of others. This past week, I attended the Opioid and Meth Summit at the Grand Geneva in Lake Geneva. How many would you say were there?
450.
450 people in this room, and I listened to speakers on the subject, I listened to current therapies, I listened to all sorts of things, but the thing I felt there, and sitting at my table, was this sense of awesome weight. That all these people in law enforcement, all these caregivers, judicial, state people were aghast. And I began to realize that this isn't something that's a state problem or a judicial problem or an incarceration problem alone. It's our problem. It belongs to us, and everybody that raised your hand today has the opportunity to come out of that isolation, of that stigma, and be honest about it. Everyone who is struggling with this disease doesn't have to have a story that ends like my son's. The only way that we can find hope, I think, and it's perfect for the church, because we have what the author of the definition, current definition of addiction, said in his address to us. The opposite of addiction is connection. And so we're going to say a little bit more in a few minutes about what that connection might look like, what the Greater Milwaukee Synod is doing to help congregations create climates of connection so that people can address this crisis, which, as we've seen, is huge. What is the statistics? 130 people a day are dying of this. So that we can be the connectors that need to happen for the people who are suffering and their families.
Well, Molly, for all of us here, unspeakable sadness and sympathy for you, what you're dealing with, and what you've had to deal with. Tough. The next person who's going to share with us is Christine Bremer. And Christine has worked at St. Mount Zion Lutheran Church as office manager for a good number of years and is nearing retirement from that.
I am retired.
Have retired from that. Yeah. But she has a story also about the impact of opioids. Chris?
Good morning, everybody.
Good morning.
Morning. I have lived with a heroin addict for the past 17 years. This person is my son, and he has just turned 39 years of age this month. This is quite long-lived for someone suffering from this disease. We have been through many, many traumatic experiences. I'm not going to share those with you, but just sufficient to say he has survived over 12 near-death overdoses in our home alone, and a few outside of our home. So I'm just going to talk a little bit about why I consider this a disease and not a failure of his moral character. Disease is defined as a disorder of structure or function in a human, animal, or plant, especially one that produces specific signs or symptoms or that affects a specific location and is not simply a direct result of a physical injury. Also, a particular quality, habit, or disposition regarded as adversely affecting a person or group of people. There are four main types of disease: infectious diseases, deficiency diseases, hereditary diseases, including both genetic and non-genetic hereditary disease, and physiological diseases. I believe my son's addiction is both hereditary and physiological. In an article written by the director of the National Institute on Drug Abuse, Dr. Nora Volkow, states, to explain the devastating changes in behavior of a person who is addicted, such that even the most severe threat of punishment is insufficient to keep them from taking drugs, where they are willing to give up everything they care for in order to take a drug. It is not enough to say that addiction is a chronic brain disease. What we mean by that is something very specific and profound, that because of drug use, a person's brain is no longer able to produce something needed for our functioning and that healthy people take for granted: free will. There are factors in my son's life over which he had no control, which provides some very good reasons why he has this disease, including prescriptions for OxyContin for a shoulder injury when he was in his teens. I began to understand my impossible expectations of him as I compared his disease with my sister's cancerous brain tumor, which took her life on August 31st. No one blamed her when the cancer returned, and there was no more hope in treatment. No one expected my dear sister to work any longer, to care for her home and her husband. We all took care of her, for she had lost her free will. She was surrounded by a host of loving and caring people in the final months of her life. I am sure each of you here this morning have been affected in some way by the disease of addiction. We will speak a little bit more later about a video essay which we hope to show here at St. Matt's called Pleasure Unwoven to help us better understand this devastating disease. And we hope if you are interested, you will be able to sign up today. Thank you very much for coming this morning.
So from the interaction that Chris and Molly and Bob and I have had together, and we've gotten acquainted because we served on a task force that served our synod by developing a group of guidelines for the bishop to use in dealing with rostered ministers, pastors and deacons, who are dealing with addiction. Our synod didn't have anything like that, so the four of us and a few others put something together. The Synod Council just approved it and is going to be now published and used by our synod. And it's a very compassionate and very thought-provoking guidelines based a lot on what you just heard from Christine here, saying that addiction is not a moral failure, it is a disease. And it affects your brain in such a way that you think up is down and down is up. That's how serious it is. So thank you, Chris, for sharing. So Chris has like the embodiment of patience. That it just exudes that. Really appreciate the model that you provide for us in dealing with people who have this illness. The next person is Bob Thays, Pastor Bob Thays, who worked for many years as a drug and alcoholism counselor. And he more recently has worked as a parish pastor, but retired from that a year or so ago. And Bob had an experience with some drugs that he wanted to share with us.
Thank you. What I have to say is not terribly dramatic. It was when I was going to seminary, and I had a sinus infection, and the doctor at one of the clinics up there in Minneapolis prescribed an inhaler for me. And it was wonderful. Whenever I used that inhaler, what happened was all the congestion cleared up and I was fine. And so I would get it refilled. It was open. I could get it refilled whenever I wanted. I went and got it refilled many times throughout the year. And then we were driving back to Milwaukee, because I had family in Milwaukee one weekend. I was driving back from St. Paul and was about 140 miles out of St. Paul when I realized I had forgotten my inhaler. My wife and young children were in the car. I was about to turn around and go back to get my inhaler, 140 miles. And my wife talked me out of turning around. She said, we're not driving 280 miles yet for you to get that. You can see a doctor in Milwaukee and get it refilled. So that made sense to me. So I went to a clinic down here. First thing when I got to Milwaukee, went to a clinic, asked him, told him what I was on, and he said, you know, this is terribly addicting, don't you? And I said, no. And all of a sudden it occurred to me, I was addicted to that. The fact, and I never thought about it. The fact that I was willing to drive all that distance to get something that I thought I needed. And the congestion wasn't that bad. The sinus problem wasn't that bad. I mean, I functioned well without any kind of inhaler. At that point, I just stopped taking it. I stopped using it and said, that's enough. No, I'm not going to have something like that. But what struck me, and I've worked in addiction for over 40 years, was how subtle it can get started. I never knew I was addicted, but I was. Yeah. I think I'll.
Thank you, Bob. So we were very fortunate to have Bernestine Jeffers with us this morning. Bernestine works for the State Department of Health, and she is particularly focused on the area that we were talking about this morning. So Bernestine brings a wealth of knowledge. We've limited her to only about 10 minutes, but she's got plenty more that she could share with us. But I really appreciate you being here today, Bernestine, and look forward to hearing you.
Thank you. Good morning to everyone. I'm going to try and shorten everything into this 10-minute space here. Couple things before I get into some of the state resources. One being I wanted to provide some additional stats as it's related to Milwaukee County specifically. We had talked about earlier deaths in Wisconsin. And I just received a report from the medical examiner here that actually breaks down the various narcotics. Someone had mentioned about fentanyl. And so far this year, we have had 155 deaths in Milwaukee related to fentanyl alone or in combination. What we're seeing is the various drugs that come through this area of the state. They are now not just, say, cocaine or just heroin. A lot of them are being cut with fentanyl or some other type of substance. The total drug deaths for this area so far in 2019 is 274. We are estimating, or the medical examiner has estimated 346 total deaths for this area. The number of autopsies done in Milwaukee County so far this year related to drugs is 924. We are on target, or the estimate for the year is 1,167. I bring that up to also emphasize the seriousness of this opioid crisis. Some people think it's a rural, some think it's an inner city. It is a statewide, it is a nationwide issue we are dealing with right now. While Wisconsin is not in the top 5%, we still are in the top 5% for alcohol. So another case we look at here is how many of these cases also include what we refer to as polysubstance use, either alcohol in addition to an opioid or alcohol and some other substance. The other thing we're seeing, methamphetamine increase across our state. For years, it had just been on the western side of the state, and then it kind of plateaued out and disappeared. Over the last couple of years, that's why we have a summit called Opioids and Meth. We have seen it travel, and now we're seeing it. We thought Milwaukee was safe because of the kind of increase or the steady use of cocaine here. Now we are finding we not only have opioids, meth, cocaine, opioids, and alcohol. We are finding meth coming into Milwaukee County as well, southeastern Wisconsin. Some people think it is coming from Illinois. The drug cartel has gotten very business savvy on how things are shipped. They come in the mail, they bring them in. In Marinette County, as an example, we do a lot of shipbuilding up there. They come through the seaport, so to speak, or whatever, the lakes, the Great Lakes up there. So just to give you some ideas of where this is coming from. The other, okay, Lowell, I forgot to look at my clock before I started.
You're doing fine.
So on the prescription use side, we have seen a decrease. However, what is some anecdotal stories or information we're receiving is because doctors reduced or started titrating, reducing the prescriptions that were released, and perhaps the pharmacists can talk to this more when they come up. People are seeking drugs from a street level. So they're going out because they are still in need. So we've shifted from prescription in some areas, that's not necessarily all Milwaukee County, to seeing an increase in what is referred to as illicit drug use. And that's because you can buy heroin cheaper. You can also divert drugs if someone is in a particular opioid treatment center, opioid program. There are a number of ways that drugs are still being obtained. Some of it is because of chronic pain, and now after all these years, you are removed from that drug and still have a need for that drug. The other population we don't talk a lot about, but I want to as I scan the room, and I will say I'm a member of the senior citizen group as well, thinking about retirement and stuff, but over 60. And that's all I'll say. I won't say how long. But that population for years has received a lot of pain medication for chronic illnesses. It could be arthritis. I was wondering if I was going to have to stand because my knees don't like standing a long time, okay? But, you know, we give medications. We've had long or medical issues that may require surgery of some sort, if it's cancer or whatever, and you need something to numb that pain. That group we have not looked at and spent a significant amount of time. I received calls in my office where individuals have been on these medications and where they're viewed as medically frail, so a lot of programs will not take them on. And I'm talking about outside of your pain management clinics a lot of time. And these are the individuals that they are reducing the prescriptions, or people are removing them from their homes depending on their age and what the traffic is in their home. So that's a whole nother conversation we could talk about and perhaps have that as a topic another time. But I want to get back to some of the stats, and when Lowell was presenting some of the statistics, can you hear me without this? Okay. I thought, you know, we need to go back and add a third or a fourth to that. We didn't talk about the Vietnam War, and that's where a lot of opioid use, a lot of our soldiers some veterans may be here today, but that's when we saw the first or heard about it in our generation. And I think we need to look at how many individuals that served that also came back with an addiction to heroin, and add that so we have 4 levels. So we're going the Civil War, World War II, and the Vietnam War, because there were a lot, and that used to be a question I would raise in our meetings. How does this differ from the 60s and 70s as individuals return? So I think I'm going to have them pull some stats on that, and we take a look at that as well. The other one, all the information we're sharing, including the handouts that have the various links, the data is available to anyone in this room. We have developed some new dashboards. You can go out to the DHS website and you can look up anywhere in the state to find out what the impact is on a particular drug. There are also stats on alcohol and other drugs that are out there. There's a specific page for opioids as well. To the type of programming we have available to the residents of the state of Wisconsin, right here in Milwaukee, we probably have about 4 what we refer to now as opioid treatment programs, formerly known as the methadone clinics. They provide medication-assisted treatment, which includes Suboxone, methadone, and in some cases Vivitrol. So that's one. There are office-based opioid treatment in your family practice docs, some of them. So far this year, we have trained over 214 prescribers. You now, by federal law, do not just need to be an MD to obtain this certification. So we have some advanced practice nurse practitioners, we have physician assistants that have all been trained. I received notification to continue that program. We do a training once a month somewhere in the state. We've done 3 here at the Ascension facility right on Highway 100. We will be continuing. They asked us to cut it off at 30, and I think we're averaging about 40 here in Milwaukee. So it's not just Milwaukee and Madison, it's anywhere there is a need for the medical community, we are working with them. If you have a loved one and you're not sure where to go, you're looking for resources, and this is something key for your pastor group too. There is a 211 number. Here I think it's Impact 211, but there is a 211 Wisconsin that will work with you to find not only the service, but if the individual does not have insurance because they've lost their job, the family has written continuous checks for treatment and stuff, they will work with you to find funding. At the state, we probably now have about 10 programs. You do not need to have insurance to qualify for these programs. As Molly asked what my actual title was, one of my major jobs over the last 10 years and what I was hired to do for the state was to oversee women's substance use services and policies, contracts, and trainings for those grantees that are involved. There are 3 programs specific for women's treatment that are funded by the state of Wisconsin, located right here in Milwaukee at Maida House, UCC or United Community Center, and Community Advocates. UCC and Maida House have like a campus setting. All levels of care are provided except for inpatient that you find at a hospital. Freighter is in the process of developing a medical unit that will also treat substance use issues for those with chronic health issues. So resources here in this part of the state are very rich, as we use as our term. Whereas you go further up north, you may not have as much. This does not exclude, I don't know the number of counselors in this area, but there are several state certified clinics that provide mental health and substance use services in our state, in this county. And actually the majority, I believe, are here, right here in Milwaukee County.
Pretty good?
I'm pretty good? Okay, if you say I'm pretty good. So, there's the State Opioid Response Grant, a relatively new one. It was the state targeted. The feds are not real fancy with acronyms. So for 2 years it was, the STR, or State Targeted Opioid Response. And now we are starting our 2nd year of the State Opioid Response. Basically, we look at all the high-need counties in the state, and a formula is designed by the finance people. And from there, we distribute funds to counties, since we are a state that works on a state-county setup. So again, there are grants here. Milwaukee also has a 24/7, as in it's open 24 hours a day, opioid treatment center in West Allis. I think that'd be the last one. Okay. I can make a handout for you of your resources here in Milwaukee County. I didn't think about that, okay?
So you can get a feel for how much commitment Bernstein has had to this for many years. So good to have people like you working for the state and working on our behalf, for sure. Great. So this next woman you already know, and that's Darla Hiam. And Darla has some history with this illness that she was willing to share with us.
Like Molly, I got the phone call. It was in July of this year. I was on vacation in Canada, and I got a phone call from my stepson telling me that my great-nephew died of a drug overdose in Minneapolis. The rest of the phone call, I listened to my nephew's concerns about, or my stepson's concerns about his children, ages 16, 18, and 21, and how he keeps them safe from this disease. So I want to just tell you a little bit about CJ's story. It's very similar to Justin's story. This kid was funny, he had a magnetic personality, everybody liked him, he was a loyal friend, protective brother, he was very talented, he was an accomplished guitarist, he was a great singer, he was very athletic, he played ice and field hockey in Minneapolis. He was active in his church of Mount Olivet in Minneapolis. He was employed up until the time of his death, and at 14 he became addicted to drugs. During the past 7 years, he's been in and out of treatment programs, whether they've been outpatient or inpatient or individual group or individual treatment or group treatment. And every time the family had hoped that this was going to be the one. But the programs only provided a temporary respite, and they could not undo the damage that had been done to his brain. At 20, he suffered a stroke, and he lost mobility on the right side of his body. For the last year, his father had been working with him in the pool to gain mobility back. This year, he completed another treatment program, another one that gave the family hope that we would have CJ back. And in July, CJ introduced his new girlfriend to the family. So there was a lot of positive things going on. The day he died, he was moving into a new apartment. No one knows what prompted him to take drugs that day. But whatever the dose was that he took, it may have been normal before his treatment, but after he'd been off the drugs for a while, whatever dose he took was fatal to him. The family reactions have been really interesting. CJ's mother says that she always loved him, but he was hard to like at times. She still says that she is shattered, that love, treatments, and all of their efforts weren't enough. CJ's father and grandfather, both who are fix-it guys, have great guilt that they didn't do enough to fix it. CJ's grandmother, my sister-in-law, is angry at CJ for causing so much pain for the family. She goes between grief and anger, back and forth. His sisters and cousins are in pain, facing their own mortality through CJ's death. And the rest of us, we are all afraid that one little action can send our children, our grandchildren, our nieces, our nephews down the same path. At the funeral, the grief was overwhelming. The family grieved the loss of the bright light that was CJ's. His friends grieved the loss of his companionship, humor, and talents. And every parent grieved the thought that they might sit in the front pew in the future and bury their child. We all grieved that if drugs could take CJ's life, drugs could take anyone's life. Now, drug addiction is a stigma disease. We've heard that already. There's little sympathy and a lot of blaming. And if any of you said this to me over the last 3 months when we've talked about this, you are absolved. But the first thing I heard was, well, working mothers, that's the problem. CJ's mother was a stay-at-home mother. She was very active with children. Oh, it's because they don't have any religion or religious background. CJ was active in the music ministry, the youth ministry, and Mount Olivet Church. He had too much leisure time on his hands. Well, this kid was taking guitar lessons and music lessons and playing ice hockey and field hockey. And the one that has really gotten under my skin recently is that people should pass drug tests in order to get food stamps, as though drug addiction is something that can be turned on and off. Drug addiction, including alcohol, changes the brain chemistry, and it's insidious in the way it attacks the individual. The thing we need to know is that there should be no shame in someone being affected by drugs. Just like there's no shame in heart disease, cancer, Parkinson's, Lou Gehrig's, or any of those other diseases. We turn around, we offer support to people with physical diseases, but we don't do much for the people affected by drugs. We need to show the same compassion to the drug-afflicted family that we do to those to others with health concerns. So are there any bright lights that came out of this? I watched at the funeral how Cass's circle of friends from Mount Olivet swarmed around her. It is obvious that that group of women has walked with her during the past 7 years, through all of her hopes and her fears and her anger and her crying, and she did not make it a secret, and they did not make it a secret, and they did not judge her on it. They did not call her a failed mother. They did not say it was something wrong with CJ. It was just that it had happened and they were there to help. Mike and Kath selected the organization Shattered Proof for memorials. In addition, it's a national organization that provides treatments and advocates for programs and services, but they are also working hard to remove the stigma. And I encourage you to check that website out. Mount Olivet also has a mental health task force that helps them frame the congregational response to mental health issues, including drug addiction. They set aside shaming and provide compassion and support for the individuals and families. So what can we do here? We can create a support group for families that are affected by drugs. We already have support group for caregivers, but I've got a feeling that people who are dealing with drug issues would feel uncomfortable going into a group of people who are dealing with the cancers and the Lou Gehrig's diseases and the other diseases. We have the Stephen Ministries that provides one-on-one support, and that's an excellent tool for us to have. But it does nothing for the congregation as a whole to embrace the individual. We need a non-judgmental support network here, one that enables many of us to step up and give the compassionate support to the individuals who are affected by this. And for those of us who are lucky enough not to be impacted by the drug-afflicted diseases, we must suspend our judgment. We must offer support. It is incumbent upon all of us that we share God's love and grace to the drug-afflicted among us, whether it's the individual, the family, the friends, the extended families. And with that, I got some information today on a practical toolkit for the opioid epidemic, which we will be dealing with in social ministry in the next couple months. But it is something that the congregation is going to have to step up and make people feel welcome that they can discuss these types of issues. Because we are not going to say, oh, it's your fault because you worked. It's the video game's fault. It's not. It's a disease that we must help and we must be compassionate about. Come on.
So you've heard a lot of pain today, and we haven't been able to devote very much time to it. But one way to honor the stories of Christine and Molly and Darla would be to respond to Darla's invitation to say to Darla, I'd like to help in some way. I may not be an expert about it, but I'm willing to get more education, find some way to be a support to people dealing with these, often in secret, dealing with these very, very devastating illnesses. Darla mentioned brain disease, several other people had too, and I want to give our friend Christine a chance to promote a program that she's offering to St. Matthew's.
Several years, not that many years ago, I had watched this movie, Pleasure Unwoven. One place to get a lot of help for people who have a family member, loved one, or friend who's addicted is Nar-Anon groups in Milwaukee. And this is where I saw the film Pleasure Unwoven. After seeing it, I purchased the film because I thought it was so good, and we would love to show it here at St. Matt's. And have a little discussion time after. It would probably take about 2 hours for the film and discussion, or we could do it in 2 separate sessions. It is done by a Dr. Kevin McCauley, who was an addicted person. He is a qualified medical doctor, and he focuses in this film on the important question about addiction. Is it really a disease? And it kind of goes both ways and helps you to understand the workings of addiction and what happens to the brain when this occurs. He uses the spectacular landscape of Utah's state national parks to describe the brain areas involved in addiction. And so it really helps us through this imagery to understand what happens. So we do have a sign-up sheet up here. You can put your name, phone number, or email, and when we get a date to show this. If there's enough people interested, we will contact you. So, thank you.
So Molly has some words to say about the Synod resolution for developing an opioid task force and an opportunity for more education from people at St. Matthew's and throughout the Synod. Molly?
A year ago, about this time, I attended a opioid crisis faith-based summit in Milwaukee. And emails went out to, I'm sure, all the clergy in southeastern Wisconsin. There were several sites. But I attended that, and there were a handful of clergy there. And I was dismayed and confused. And then I met with Pastor Joe Ellwanger.
Oh.
Joe is the king of Synod resolutions. And he said to me, we got to get a resolution. So that's what we did. And I authored a resolution, which is you can take a copy of when you go. And the front sheet of the paper is the whereases, the statistics, the staggering things. And the other side is the be it resolved, which are practical ways that congregations can respond to this. When I joined the group that was helping the bishop to form guidelines, that specific task was oriented to helping the rostered leader with their addiction. And out of that came, this affects so many more people than just the addicted, as you heard. So we decided to form a group to respond and help families, which turned into a task force that has called for in the Greater Milwaukee Synod. There are efforts throughout the church, ELCA and other denominations, but in the Greater Milwaukee Synod, we're hoping to pull a task force together to do exactly what you're doing right now. And I want to thank you for being here today personally, because this is the first time that I've been able to address a congregation. I've been going to workshops, but as I sit here, I think to myself, there's hope. You know, that if we can see that this is a problem that affects all of us, and not just getting someone into treatment, but creating an environment where an addicted person can not only seek help, but continue to get help after they've been through treatment. A place that understands relapse for what it is. And give that kind of grace and peace to this crisis that nothing else can. The church is perfectly poised as an organization. From baptism to death, we are dealing and helping people live. So I invite you to look. There's a Facebook, Opioid Task Force, Greater Milwaukee Synod, that you can keep track of, and contact me or Lowell or anybody for more information on that task force. But please take that resolution with you.
There has been the initial task force has developed and is developing a program that's going to be offered here at St. Matthew's as part of the leadership conference that our Synod has every year in February. So keep your ears open to that, because this task force is going to give a presentation, provides more education about this whole subject matter. We have 3 handouts here. One are some websites that you may be interested in. The second one is the guidelines that we prepared for the Synod to use for rostered ministers. And the third one is the resolution that Molly was talking about. We have another person here who's involved with opioids, and she is a pharmacist. Her first name is Kristen. And I'm wondering if you could just offer some comments on any changes that you've seen in the way opioids have been prescribed and used at the VA hospital. You want to just stand up?
Hi, I'm a pharmacist.
What's your last name?
Kristen Charlson.
Charlson, okay.
I'm a pharmacist at the VA. I don't work, I work kind of in a different area. I don't work directly with narcotics, but I can let you know what we've done at the VA. over the years, more recent years, prescribing has gone down, as it was noted by some of the speakers. So I think that's been a good change. And one of the other areas that I wanted to mention was naloxone is available now, and that's the reversal agent for narcotics, and it's now available without prescription. So there was a Health and Human Service organization for the federal government, HHS, put a notice out that this is an important tool but not a solution for patients who patients should have this. People should have this available if they're on high dose prescription opioids, those misusing prescription opioids, those using illicit opioids, and family of those who might be in those categories, or people in the community who are around people who might be having access to opioids. So the VA is handing Narcan out to anyone. So.
Oh, to anyone.
Well, anyone in that in those categories.
Yeah.
So anyone who has high
Great.
risk.
Yeah. Another St. Matthew's connection. Oh, this is the other Kristen. Okay. Another pharmacist.
Thank you for being here.
Thank you.
Yeah.
Thanks, Pastor Matt.
Oh, you're welcome. Sorry to out you.
No problem. So I didn't see Kristen when I walked in. I'm Kristen Hansen. I'm also a pharmacist. Similar to Kristen, I also work a little further removed, and actually more of my work at Frederick Hospital has been dealing with the pain management strategies. And this is, it's great to hear all these stories and the connections, and I feel like I don't have as close of a connection with these things. But what we're trying to do in the inpatient side and in the ambulatory clinics too is identify those patients that have chronic needs, chronic pain needs, chronic opioids, looking at where there's some risk factors and what can we do, rather than just blanket prescribing the same opioid or the same high dose for maybe a minor surgery. Can we start with something else? So there's been a lot of efforts. I'm glad to hear we have seen some reductions. A lot of it is driven by our payers, and it's actually one of the most effective ways, because we get called as pharmacists that we can't dispense a prescription for that many pills at once for someone. So a lot of work still needs to be done. Happy to help out and lend perspective. I'm sure Kristen is as well, just to learn a lot ourselves as we go through this. So thank you.
Do you have any idea what happened to 310 million opioids that were sent to Milwaukee County from 2006 to 2012?
The prescription ones or the non-prescription ones?
All I know is that the drug company sent them here.
Mm-hmm.
And I don't know, that's 47 per person per year.
It's a lot.
Yeah.
Well, and what I've seen, and I've seen this both when I've had minor foot surgery, when, we've had wisdom teeth out in the family, there's the sense of, well, we need to have an opioid prescription just in case there's a lot of pain. And so rather than just prescribing 10, well, let's prescribe 30 because just in case. And that mindset is changing, but it's hard to change those habits. Yeah, because then they stay.
Wow. Thank you.
Yep.
Matt?
Two pieces. If you have opioids sitting on your house, don't flush them. No. We have mail-in pouches that get properly disposed of by the city of Milwaukee. They're in the office, and they're always available. So if you want one, for any meds, but especially for opioids.
Bernstein wants to tell you when the drug take-back program is.
October 26th, right?
Correct.
Yeah.
You just told us. In addition to the pouches here at your church, you can also take them to your local pharmacy. I believe the 26th is next Saturday. So that's a National Take Back Day. You can also, in Wauwatosa, take them to the police department, and they will take them in. I believe they still have their grant where you can return them throughout the year. There's like a vending machine where you place them in there. I was gonna give you one other on Narcan or naloxone. We fund a large naloxone distribution grant. ARCW here in Milwaukee is the grantee for that. They will come out, do trainings, as well as provide the Narcan to individuals. So as you're planning, this may be something that you would like for them to come and provide a training for your congregation.
Thank you. One more, and then for questions. Marion Hines, been involved with Rogers Memorial Hospital. I thought she might want to share a little bit about what resources Rogers has. Marion?
Thanks, Lowell. Rogers Hospital has various levels of care for people who struggle with addiction. And a good starting point is their general 800 number. If you have someone that you love or that you know that needs help and you're very concerned about them, you call that number and talk to someone. Someone will listen to you, will give you advice as to what would be a good next step. And it's available 24/7. We have at Rogers inpatient for detox and really super sick people. We have partial programs that are offered at Oconomowoc, 110th and Lincoln, right here, Brown Deer Hospital, Kenosha, and the partial programs are offered every day of the week. They also have day treatment, so people can come for 4 hours or 6 hours, whatever, if they run out of insurance time. It is pretty much insurance funded, but it is a fabulous resource with great people.
And I think add to that, that you can have a free assessment
Assessment,
that
right.
lasts over the phone, maybe an hour, hour and a half, and you can really
Exactly.
go in depth as to what the person or you yourself or
Right.
someone you love is dealing with.
And also the
Free.
website.
Free.
Yes, the assessment over the phone is free. If you go on the website, it has all kinds of resources there as well.
You also have one of the few adolescent
Yes, yes.
Sure. You have one adolescent program?
programs. We only have about 2 in this area, and Rogers is one of them.
Carl?
Yeah, it's just my gut as a retired pastor, and I think the elephant in the room, for my years of people who get hooked on marijuana in the middle age and old age, with all kinds of brain issues, as a gateway drug, and now with vaping and cannabis oil and so forth. Is that a gateway to opioids in a way? Have you just done the research on that? Because it's rampant right now. You know, and with the legalization of cannabis.
I am not aware of any research currently being done on the two in our state.
Okay,
It
we have,
doesn't mean it doesn't exist.
Don.
Oh, why do you think America is turning to drugs? Any ideas?
Why is America turning to drugs?
Not just us. Sweden's got a big problem with it too. Sweden's afraid of the fact that sooner or later, fentanyl is going to go to Sweden, and they'll start seeing the deaths that we have.
So why is Sweden and America turning?
Well, I think one of the things that affects usage is cost. The cost of drugs has gone down considerably. The drugs coming out of Mexico cartels are easily accessible. As the prescription drugs, which used to be a source of illicit drug use, as that goes down, as we heard, there's people are going to look elsewhere. And through the dark web, does anybody know what the dark web is? It's something that you can access that's not out there publicly, that can be trackable. The dark web, you can get drugs like that. And you never know what they're going to be laced with or what they involve, because it comes pure out of Mexico and then it's cut and mixed, sometimes inconsistently. So you could get a package of fentanyl that is laced and it wasn't mixed properly, so part of that bag will be really deadly and part won't. So it's a real dangerous time, but cost is really, I think, one of the drivers of increased usage.
So I'm hearing availability making the difference.
Availability and cost.
There's an organization on the north side of Milwaukee called RedGen, REDGEN, and it's an organization devoted to helping children become more aware of what their emotional and psychological needs are, being able to talk about those in a safe environment, to do a preventive kind of work that gets to the children before they have the temptations and the needs of dealing with drugs. So RedGen, The website for Red Gen is on this list up here too. Connor?
The question about why do we turn to drugs, and I say this not as out of judgment but out of love, is that all addictions bring some degree of a transcendent experience, and I believe in my heart that all addictions are a form of us seeking to fill in our heart a place that only God can do. And I do think that it's a failure on our part as a community of faith, that narrative of that the opposite of addiction is connection. There's something wanting in how we are in community with each other, that our young people, in some cases, in many cases, they're seeking medical help, and then that leads to the difficulties that they have. But us being more authentic with each other and putting God in all of his magnificent grace at the center of our community with each other, and helping each other and supporting each other and not judging each other, I think is an important place of the struggles of, we spoke today about the addictions of substances, but there are many addictions that are befalling us as a community, and they're all forms of idolatry. That's my conviction, and that we comfort each other, or we accompany each other by being Christ to each other, loving each other when we're at our least lovable, walking with those who are suffering in pain. There is a spiritual dimension to our failure as a community, and why there are so many forms of addiction around.
Thanks.
Simple question, what is the definition of an opioid, so I know what to look out for? Is it all drugs? Is it addictive drugs? Is it marijuana? I don't know what an opioid is.
Oh boy. Pressure's on. I will try. I guess I think a lot of those are some of the pain medications, the morphines, the fentanyls, the oxycodones, the oxycontins. Marijuana, I don't believe is technically an opioid, but I don't know where you draw the line versus one versus the other. But it's those medications with a very addictive quality. So I guess that's probably the best. And it has certainly some ramifications in terms of slowing your heart rate, dropping your blood pressure, slowing down your respirations, and that, it doesn't sustain life if you take so much.
All right, thank you.
Does it have to do with what part of the brain that drug targets?
Yes.
Yes, and the makeup, and the structure. This is way back to pharmacy school, so I'm sorry. The structure of the drug and things like that as well.
What I will do is send a list to Lowell that he can distribute to the group, kind of defining opioids, and like I talked about cocaine and methamphetamine, those are not opioids. Yeah. Those are actually stimulants. Right. So I'll send a clarification so you have an idea, and include on there the prescribed as well as the illicit.
And what is vulnerable to addiction?
Okay.
I'm puzzled. In 9th grade, by the way, I'm 72, in what they called it health class then, we were cautioned about illicit drugs. Opiates were specifically mentioned. Others also came up in that discussion. So we had some sense that there was something bad out there you had to watch out for. Now, some of these people in my class are physicians, and they knew about it back then, and why are they not dealing with this? I find a problem. We want to prosecute the drug companies, and duly so, but the physicians had a 50-50 proposition in the deal. When they had 8 years of education and more, advanced chemistry, et cetera, and they weren't cautious when they would prescribe them and work with people, I'm just puzzled by that. Any comment?
Yes.
Okay, this is gonna probably be our last comment because it's 2 minutes to 11 and worship starts at 11, so for those that are going.
Pharmacists can speak to this, but there was a understanding in medicine years ago that the vital signs to keep a patient in recovery, not from addiction, but from anything, was your heart respirations, your temperature, and your pain level. That there was an understanding that pain was really detrimental to recovery, and so the pharmaceuticals encouraged doctors to prescribe as a health remedy. And I hate, my deceased husband was a physician, and he would get the calls on Friday night, you know, people wanted their prescriptions renewed, and he'd say, you have to see me Monday, and well, I don't have enough, well, see me Monday. So doctors have been working with this, and I know that years ago, Aurora Healthcare would hand out a discharge paper that said, don't hesitate to take the drugs your doctor prescribes for you. You cannot be addicted to these. So there was, it wasn't, from the doctor's part, it really wasn't, as we would want to say, to make money. It was really an understanding that pain management was really important, and these drugs could be important in that. They've since changed that, as we heard over here. Pain and management is completely different than it used to be, and rightfully so.
So thank you to Bernestine, Bob, Christine, Molly, and Darla. This is, I believe, I hope that this is the end of the beginning. That this is not the end of this conversation, but it's the beginning of it. And that St. Matthew's as a congregation and you as individuals will take further steps to educate yourselves and be involved in this crisis. So that's it for today.
Thank you.